Hello, my name is Jason Salemi, and I'm an associate professor of epidemiology at the University of South Florida's College of Public Health. Today is June 27th, a Saturday, and unfortunately, as you can see by the official Florida Department of Health coronavirus dashboard over here, this is our second day in a row with around or over 9,000 cases of COVID-19. But today, this short video is not going to discuss the rise. We've certainly done that enough. Today's topic is going to be antibody testing. Antibody testing is one of two types of tests that are used for coronavirus. One is kind of the swab test or the saliva test, those things that are actually detecting for virus right now, versus the antibody test, looking for whether or not your immune system has developed antibodies to the virus and actually detecting those antibodies as proof that you have been exposed. And so there's been some controversy around, how is it used for reporting? And so to give you an example, this again is the official Florida Department of Health coronavirus dashboard, and they choose to report cases only based on viral tests. They do make information on antibody testing available, but it's not included in its overall case count. If you look at the community coronavirus dashboard, which was created by a former Department of Health employee, she chooses to present an overall number that includes both viral test cases as well as those individuals who have tested positive on the antibody testing, and then of course reports them separately as well. So I want to discuss just a few topics very briefly that have to do with the antibody tests, that I've heard on social media and that I think might be helpful to digest the information. So issue number one. If you've read anything about the antibody test, you've probably heard words thrown around like sensitivity, specificity. You may have heard, antibody tests could have a high false positive rate. So I want to help you make some sense of all of this in a very simple fashion. And you'll have to forgive me. Again, my examples are rudimentary. My graphics are even more rudimentary, but hopefully it does help. So when we develop a test like this, like an antibody test for coronavirus, step one is to establish the test performance metrics. This is going to be your sensitivity and your specificity. Those are going to be your key characteristics of this test. And so what do I mean by it? And so for these examples, I'm actually going to use the numbers that I've seen most recently in terms of the sensitivity and specificity metrics for the coronavirus antibody test. And so the specificity of this test is 99.8. Sounds good, right? Really close to 100%, but what does that mean? So I've got 1,000 individuals on the screen right now. And so imagine we had a crystal ball. We knew the absolute truth. None of these 1,000 people have SARS-CoV-2, which is the virus that causes COVID-19, right? So a perfect test, right? Again, none of these people have the virus. A perfect test would not show antibodies to that virus for any of these people, right? They would all test negative. What does a specificity of 99.8% mean? Well, it means that out of these 1,000 people who do not have the virus, only 20 of them will have a false positive. Even though they don't have the virus, they will test positive. So again, you may think, well, that's not good for those 20 people, have them, think that they're immune to the virus or have antibodies to the virus. But I would say out of 1,000 people, that's not too bad. So that's specificity. It's how well are we doing at identifying the people who do not have the virus, right? So as you can imagine now, I'm going to transition to sensitivity. Sensitivity, I've seen the most current metrics for this is about 90%. So again, I've got 1,000 people on the screen right now. The difference is, the truth is that they all have the virus, right? So a perfect test would identify all 1,000 people as positive for the virus. So what does a sensitivity of 90% means? It means that 100 of these 1,000, 1 in 10 people who take this test, even though they have the virus, will test negative, right? So that's what a false negative is. So, sensitivity is all about, the ability to accurately identify those people with the condition or with the virus in this case. So that's just a little bit on what those two things mean. But once we develop a test and we know its sensitivity and we know its specificity, it's time to now implement this in the population. That's what we want to do. We want people to get tested and we want to know, what do those test results mean? Can I trust a positive test? Can I trust a negative test? So what happens when we implement this test in the population? This is where it gets a little, it depends, right? So again, remember our test characteristics. 99.8% specificity, 90% sensitivity. I'm going to test 1,000 people from the population. So now I'm going to give you a couple of scenarios. Scenario 1. The truth is, which again, we don't know, but let's assume that 5% of people in Florida have the virus. We would say that the prevalence of the virus is 5%. If that was the case, and we test 1,000 people with these characteristics of the test, the sensitivity and specificity, this is approximately what we would get. We would get 47 of those 1,000 people who tested positive, and 2 of those tests will be a false positive. They actually will not have the virus. So that's 1 in every 24 positive test results is a false positive. It's inaccurate. So, some people might say, well, that's a lot, that's 4 in every 100. Other people might say, well, that's not too bad, right? That's not too many false positives. Well, if we just change the scenario, let's say in Florida, not 5% of the people don't have the virus. Only 1% of the people have the virus. If the prevalence changes, specifically, if the prevalence of the virus goes down in the population that you're testing, now what would happen to those 1,000 people when they get tested? Well, we'd have about 11 who test positive, and 2 of them will be false positives. So that's 1 in every 5 to 6 tests. So 5 or 6 people test positive, 1 of them is a false positive. So now we're coming into a situation where that becomes a little unacceptable in terms of the accuracy of the test. So the extent to which this test works, what we call the positive predictive value and the negative predictive value. What does a positive test result mean in terms of accuracy? What does a negative one mean? It changes depending on the prevalence of the condition in the population. So, and I want to show just how sensitive this is, right? So I just gave you a scenario with a test, if you're looking up at the top, 99.8% specificity, 90% sensitivity. The only thing I'm going to change is the specificity from 99.8 to 99.0%, right? The sensitivity remains the same. So still very high, but look at just that little change, what the difference is. I'm still going to test those 1,000 people. In that situation where we had 5% of the people who had the virus, the prevalence, and 1%, right? 1,000 people get tested. In this case, in a 5% prevalence scenario, 55 people would test positive and 10 of those would be false positives. 19 would test positive if the prevalence was 1%, and 10 would be false positives. So I want to really hone in on that bottom one, what that means, right? That's more false positives than true positives. So if we had a test that had 99% specificity, 90% sensitivity, and 1% of people in Florida had the virus, if 19 people tested positive, 10 of those would be false positives, 9 would be true positives. It's a coin flip at that point. And so obviously not very useful. So, and this is reflected on CDC's website. This is just, from one of their web pages. It says, a higher percentage of positive results may be false positives when these tests are used in people who live or work in an area where few people have the disease or the virus, right? So again, as the prevalence goes down, the accuracy of this test specifically, the number of false positives will go up. And so again, that's another way of saying the positive predictive value of the test depends on the prevalence of the condition for which we're testing. So what's our prevalence in Florida? Is this actually impacting? Are these antibody tests worthless? Or do we have a sufficient enough prevalence where we don't have a lot of false positives? Well, I just looked this up. Population in 2019 in Florida was a little over 21 million. These are the number of cases reported as of yesterday on the Florida Department of Health website. So if you that's numerator and denominator there, if you divide those, the prevalence based on what we currently know about testing is not even 1%, right? It's 0.66%. Now, huge caveats, right? Don't take me on that. I am not saying that the prevalence of SARS-CoV-2 is 0.66% because obviously this is an underestimate. Probably a big underestimate. How much we don't know. Obviously, there are a lot of asymptomatic people testing is not as expansive as we would like it. And certainly a lot of people, if they don't develop symptoms, they could actually have the virus, but they're not getting tested. So I don't know if it's doubling that to 1 point something percent. I don't know if it's 5%. It really is hard to say, but obviously what the prevalence is not only matters because, we need to understand what the prevalence of the virus is in the population, but it matters in terms of the accuracy of these antibody tests. And again, what a positive test result means. Now, I will say one additional thing. It is likely that right now, antibody testing is being administered to a subgroup of people with a higher prevalence. So even though this might be the overall prevalence in Florida, those people who are pursuing antibody tests probably have a reason, right? Maybe they felt like they were sick not too long ago. It might be a population that is getting tested that actually has a higher prevalence. They were at higher risk for the virus. So again, a lot of things go into this, but that's why if you hear the prevalence or how many people have it relative to the false positives, this is kind of what they're talking about. Issue number 2. Why do some feel it is a bad idea to combine results of viral testing and antibody testing? I don't think this is done very much anymore, but at the beginning, the CDC did it, a number of large states did it, and they just reported their daily number of cases based on people who tested positive on the viral test or positive on the antibody test. And the problem with that has to do with what each of these tests are all about. And I'm going to try and boil it down to the simplest aspect. The viral test, or that swab test in the nose that you see, or the saliva test that you see, that is detecting the virus and if you have an active infection, right? So it's what's happening right now. Versus the antibody test, which is all about kind of looking, I saw a quote that said, we're looking in the rearview mirror, right? We want to know if you've developed antibodies to an infection that you had a while back, right? So we're identifying people who were infected, but we don't know when they were infected. It doesn't help us much to kind of understand the current state of the virus. Now, it is immensely useful, right? It's helpful for contact tracing. If I find out that you have antibodies, then I know that you have had the virus, or, if it's not a false positive, I know you've had the virus. So I might say, well, who have you been in contact with? So there is a lot of utility. We certainly want to develop what we call or estimate the seroprevalence, right? How many people have been exposed to the virus, and these antibody tests are huge for that. So I'm not saying that they're not important, but if somebody took an antibody test today and they actually have the virus right now, they're probably going to test negative because their immune system takes a while to develop the antibodies that this test is testing. So again, somebody took an antibody test today and they have the virus, they may test negative on the antibody test, right? But if they took a viral test, obviously, they would end up testing positive. Okay, so that's just the differences between these. And so obviously, I'm going to use this quote to summarize it, right? Why wouldn't we combine these two things and say, here's the total number of people who have tested positive on either of these? Well, it says it right here, right? The viral testing is to understand how many people are getting infected, while the antibody testing is like looking in the rearview mirror. These two tests are totally different signals, so combining them makes it difficult to interpret and could be misleading to the public because the combined number does not reflect the rate of new infection. We're constantly looking at that epidemic curve. How many new cases today? And remember, a positive antibody test today doesn't tell you anything about that test, somebody new testing positive today, right? They tested positive sometime in the past, right? So again, a little bit misleading, and it says down at the bottom, combining a test that is designed to detect current infection with a test that detects infection at some point in the past is just really confusing and muddies the water. Now, thankfully, again, I mentioned at the beginning, the Florida Department of Health's dashboard, they do not use antibody tests in their total number of cases. They do, however, make a PDF report available on a weekly basis that does tell you the number of individuals who have tested positive for the antibody test. So they give the information so you know it, but they don't include it in their kind of day-to-day epidemic curve or total case counts. Even the community coronavirus dashboard, I will say that this dashboard does include, they do give a lump number of total COVID cases, and they do combine both the viral test and the antibody test, but they're also very clear on another portion of the dashboard as to how many of the cases came from each of these. Okay? And issue number 3, though antibody testing provides absolutely valuable info, as I've alluded to, I'm going to argue it's not that helpful to the epidemic curves. You hear every day in the news, if you're a Floridian, new number of tests, 9,600 tests today, and we're following that curve, right? Because the more people that are testing positive, taking into account the proportion of those tested who actually test positive, right? The percent positive on the test, the volume of testing, looking at all those metrics, the hospitalizations. We're trying to use all of this information together to say, ooh, are we seeing too much community spread? Are too many people getting the virus at the same time? Do we need to pull the reins back? I don't think antibody tests helps us yet to make those decisions. And that's why, I'm not in favor, of course, of lumping them together. And again, here's why. So if I test positive for antibodies today, I probably had the virus weeks ago, but I really don't know when. It could have been in April. It could have been in May. It could have been, I have no idea. I just know that I've developed antibodies to the virus. So I had it at some point, and if I didn't have any symptoms or really mild symptoms, it's not like I can think, oh, I was a little sick then. If I'm asymptomatic, who knows when I actually got exposed to the virus? So on this epidemic curve, where do I put that infection, right? So again, it helps us in certain states, and certainly as more and more people, in the absence of a vaccine, start to get this virus, we are a long way from herd immunity, but the more people that we understand have been exposed to the virus, may have had antibodies to the virus, and we know that maybe those antibodies last over a long period of time, a lot of contingencies, but that is where it could help us to understand, okay, maybe transmission is not going to be as bad because, a lot of people might be immune. Again, a lot of factors go into that and things that we yet don't know about the virus. But again, this is the problem with the antibody test. It doesn't help us in formulating this epidemic curve. Or on the case positivity rate. Again, this is something that we do on a daily basis. If I have a positive antibody test today, again, I don't know where to put myself there. I just know that, I probably, although again, remember what I said earlier in the video, there's a high likelihood of false positives depending on who is getting tested and what the prevalence of the virus is in that area. It could be a false positive, could be a high likelihood that it's a false positive. But if we trust the test, a positive test result on the antibody test just means at some point I've been exposed to the virus, but I don't know where. So again, I'm not saying anything that it's not immensely useful for certain pieces of information, but this is most likely why the Florida Department of Health does not include antibody tests on their official case counts and why they provide it as a supplemental report. It's probably also why the community coronavirus dashboard, the other one that although they argue that it's really important to report that information and they do lump it into their total case counts, that's also why they report that information separately, because it's two very distinct pieces of information. So again, I hope that helps. This was a pretty quick video for me to toss together, but I'm receiving questions from you. I'm trying to provide some answers that are meaningful. So take care. Have a great rest of your weekend.